recording this too, because then when I'm done, I'll try and save it and put it up on YouTube and give you guys a link. So whoever isn't here, they can follow and do it later. Share the. All right. Can you guys see the opening slide?
Yep, we can see it.
Perfect. Okay. All right, might as well get started. Here we go. We're going to review the score topics for pediatric surgery as quickly as we can. I'm going to start with neck and thorax, and then we're going to go all the way through trauma and all the way to solid organ tumors. Here's our topics for neck. Neck masses are going to be divided into location and whether they have, whether it's midline or lateral, whether they have pits or not, whether they're cystic or not, or solid. They're determined, the management is going to be determined by length of the present and their location. Midline, the biggest one they're going to ask you about is thyroglossal duct cyst. Lateral is going to be brachial cleft cyst, cystic hygroma, and lymphadenopathy can be anywhere, and torticollis sometimes appears on the test. So let's talk about the first one. Thyroglossal duct cyst is going to be a midline neck mass. The thyroid gland descends from the base of the tongue. They have the same genetic origins. It may represent the child's only thyroid tissue. If you get an ABSITE question that wants to imply that, it's always going to be a baby who is failure to thrive and has a midline neck mass. If it's a 4 or 5-year-old, it's not their only thyroid tissue because they would have had a problem much earlier. They're firm. They usually present between ages of 2 and 10 years of age, but can present at any age. I've actually got one of these on one of my tests in an adult. They do move when you swallow or stick out the tongue. So if you see that, that's another question, another little hint in the vignettes. They can become infected. If they become infected, they have an increased recurrence rate. The cyst trunk procedure is what you do. You have to take out the cyst, a section of the hyoid bone, as well as the distal cyst. There we go. Good, now I got the pointer. Brachial cleft cysts. They're the ones that are going to have a punctum. They're going to be somewhere in the lateral aspect along the line from the back of the ear all the way down the lateral neck to the chest. The second brachial cleft is the most common. It forms the hyoid bone, the cleft of tonsillar fossa. So this little punctum will have a tract that goes all the way back into the posterior tonsillar fossa and the back of the throat. The treatment is complete removal. Again, if they become infected, they have a worse outcome and recurrence because they get scarred and hard to find and hard to take out the whole thing. So the second brachial cleft would be the one that's most common. The first brachial cleft goes to the eustachian tube, that's ENT. Third and fourth are lower. The third one can involve the actual thyroid gland. Lymphadenopathy, rarely on ABSITE, but something to know. That's the most common cause of a neck mass in a child. This is, if you get a vignette about this, that's usually probably going to imply either infection with either cat scratch disease, if it's a firm node where they're infected, or if it's a firm node, you got to worry about lymphoma. That's going to be a firm mass, not movable, whereas an infected mass can be firm, erythematous, tender, happens quickly. Things about it is FNA is usually not the right answer for a PEDS case. For a PEDS answer, it's either going to be an excisional biopsy or at least a core biopsy because you're looking for lymphoma and you can't get the answer from an FNA. Indication for biopsy, greater than 2 cents, same as the adults. B symptoms in kids are a little different, but they run along the same things. They get malaise, they get bruising, they get really tired. They don't lose weight, they just stop gaining weight is the different one, okay? That's the next. Cystic hygroma comes up. It's a lymphangioma, which is a lymphatic malformation. If it's a lymphatic malformation, either axilla or the or head and neck region of a baby, it's sometimes called a cystic hygroma. Surgical incision is really the means to a cure. Sclerotherapy is now the thing for microcystic lesions. So you basically empty the cyst, drain it, and then you sclerose it with usually bleomycin. Now there's a new. This is probably going to hit the test in a couple of years if it doesn't hit it this year. Microcytic lesions can get shrunk with sirolimus, the medicine used in transplant. This can work and it can make them shrink. Usually microcytic, so multiple little microcysts are the ones they're treating that with. Torticollis is a right, hard, firm mass of the sternocleidomastoid muscle. Do not operate. Physical therapy is the answer. Just do not operate. That's head and neck. And then last thing on this thing is the dermoid or epidermal inclusion cysts. These can be anywhere in the body. They're ectodermal elements that are trapped beneath the skin and beneath the fascial plane. The most common thing you see in kids is in this periorbital ridge. You take them out if they're either symptomatic or they're doing something wrong. They're never going to go away on their own. They do grow slowly. Now, this little kiddo that's, big enough that it's going to affect her gaze. So you want to take it out. Most parents want them out once they're there. They're also very common in the scalp, but they'll sometimes ask you these questions. We're going to go to thorax next, trying to do this quickly this year and not be too long. All right, full-term newborn respiratory distress, chitlins in the chest. Congenital diaphragmatic hernia, what are they going to ask about this? They're going to ask that, a couple things is that mortality is still high. It is very commonly diagnosed prenatally with ultrasound. They sometimes will give you an LHR index on the ABSITE, lung to head ratios. The lower lung to head ratio, the more associated with poor prognosis. Less than 1 is really poor prognosis. Greater than 1.4 is a better favorable outcome, meaning that the lung is developing in relationship bigger than the head, which is supposed to. Between 1 and 1.4 is usually an indication they're going to need ECMO. If they're less than 1, they're going to die even if you do ECMO. They do develop respiratory distress after birth because it's bilateral lung hypoplasia and pulmonary hypertension. So persistent pulmonary hypertension, which persists due to hypoxia and acidosis, which continues to shunt the fetal shunts that are in place, and you have to treat that before you treat the hole. The posterior lateral communication between the unusual holes of posterior lateral between the pleura and the ciliary cavities. It's a Bachdelic hernia back and to the left. It's 80 to 90% of the time clinically it's found on the left side. The liver sometimes, if it's a small hole on the right side, the liver probably blocks it. And we know that there's a barrier of the liver, which is the anatomic thing you'll see, which is probably a failed diaphragmatic hernia on that kid. Morgagni hernia is an anterior medial defect. It's in front of the stomach. It's actually in front of the liver. It's along the falciform, and that's a Morgagni hernia. Left 2% of the CDH is not associated with the congenital hypoplasia, not associated with pulmonary hypertension, usually diagnosed later in life. Why is it on every test? Because the baby presents with respiratory insufficiency, and so they can answer the critical care questions about how you treat pulmonary hypertension. Both lungs are hypoplastic. Cardiac anomalies are very common. Midline defects are very common. CDH is associated with trisomy 21. If you need to guess anything, if they're asking something on an ABSITE, what is associated with trisomy 21? CDH, duodenal atresia, Hirschsprung's disease, all associated with Down syndrome. So keep that in the back pocket. Persistent fetal circulation is persistent pulmonary hypertension. The pulmonary arteries do not relax. It causes persistent acidosis and hypoxia, and you got to treat that before you treat the operation. So you stabilize. Sometimes you'll get a honeymoon period where they look better than they're going to be because they're still got higher levels of fetal hemoglobin, so they can look better. You got to ventilate them as gently as you can, give them as much oxygen as you can, and get their pH up and their PCO2 down. Keep them sedated, keep on high oxygen. You can use nitric oxide or sildenafil to pulmonary vasodilate, and then if all else fails, you can do ECMO. Rarely have I seen ECMO on the ABSITE, so I'm not going to do it tonight. You repair it. You can do it open, laparoscopic, thoracoscopic. You're going to repair the defect. You want to sew it closed. There is good data out there that despite, all the pundits, thoracoscopic CDH repair has a higher rate of recurrence, and that may be on the test. So if you do it with the scope, it has a higher rate of recurrence. Mesh repair has a high rate of recurrence because mesh don't grow. Okay. Sometimes you have a domain issue and you got to put the abdominal contents in a silo because they don't fit in the abdomen because everything's in the chest. Risk of ECMO, the longer you're on ECMO, the worse it is. They're fully anticoagulated. The longer an ECMO, the longer you have risk for head bleeds and sepsis after 7 days from the cannulas being in. Okay. And sometimes they like to ask this question. Cardiac stun happens on VA ECMO because you're delivering the oxygenated blood past the coronaries, and the coronaries are relatively ischemic when you're on VA ECMO. So stabilize, don't repair early, avoid ECMO as possible, fancy ventilating, morbidities from lung hypoplasia and pulmonary hypertension, really not the hernia, and repair when they're stable. Mergagni is what a Mergagni looks like. It's an anterior defect. It's really cool. It's got a big hole. You get to fix it laparoscopically and they go home and they flip it. Next one is a 2-week-old. They'll present a vignette with 2-week-old male in the NICU on the ventilator or just got off the ventilator, respiratory distress. The one time it's that, this obviously looks just like a first dibs, like it's a tension pneumothorax, but it's really not. Okay, these are bad pictures, but they're really not. Be careful of the tension pneumothorax in the neonate. It's something called congenital lobar emphysema. It's kind of like emphysema. The adult emphysema is with the loculated vacuoles in the lung from smoking. Kids can get this, babies can get this. It's from progressive hyperexpansion of one or more lobes of the lung. Usually it's an upper lobe. Usually it's the left side is more common for some reason. They can get a tension mediastinum from this. Causes bronchial obstruction. It's almost like acts like a congenital asthma, but really not. So the lung fills with air, but then can't empty, fills with empty, and it just starts pushing stuff over. If you have to put a chest tube in, like if they're coding or if someone's already put a chest tube in, it's okay. Let the air go out, but then clamp it, put it to water seal and main stem the other side and get to the operating room. This is when it happens with thoracotomy. This is not a scope case, and the lung just pops out like a pimple because it's just overexpanded. Next one is a cystic lesion. The thing they'll sometimes do is, if you want to guess, this could easily be a diaphragmatic hernia. It looks like, intestine in the chest, but it's the right side. And the answer is the newborn's on room air with good sats, not respiratory distress. So that is not a diaphragmatic hernia. That's a cystic lung lesion called a CPAM. These have changed names. Used to be called CCAMs. Now they're congenital pulmonary airway malformations. Prenatal sounds very sensitive. It's a cystic proliferation of the terminal airway. The terminal airways don't terminally differentiate. It can trap lung locally. It can look like CLE or even as CDHs look like by that picture. But usually know this beforehand, and they usually don't have to do anything to them in the newborn period. You can let them grow. The treatment is a lobectomy. And now we do these mostly with VATS. We wait till they get big enough to take a VAT, to be able to tolerate a VATS, and take it out. Some of the questions: do all cysts need to be removed? And the size matter? Now we can detect the smallest ones. General consensus is if you can see it on chest X-ray, you definitely want to take it out and get it done. They can get infected, which is why you want to take them out. We used to wait a year. Now people want to wait as low as 3 months to take them out because of your risk of infection. There is a cancer associated with these. It's called pleuropulmonary blastema. Again, if you think about that, it's a great question for ABSITE. It's a nice esoteric question that just is, there. See a word blastema, it's a lung lesion in kids. Pulmonary sequestration is a little different than CPAM. We think it's an amalgamation or something similar. The thing about a sequestration that is different from a CPAM is they have arterial supply. It's systemic. It's not pulmonary, usually coming off the aorta. These can be either intralobar, as you can see it on here, which, share a fissure, or extralobar, which is just a independent piece of lung that's coming off the aorta. They can occur with CPAMs, and the treatment is resection. And sometimes, a lot of times with these, you do a non-anatomic resection. And the key to this is the first thing you do is you take down and control the systemic blood supply, because a lot of times this artery is going through the diaphragm, is attaching to the abdominal aorta, so you don't want to lose control of that from the chest. A bronchogenic cyst is a hamartoma of the airways. It's a cystic lesion. It has respiratory epithelium, and so I always think this is like an extra outpouching or a failed differentiation of the trachea or major bronchi. These are a pain because they're always central, they're always near the carina, and the only treatment is you got to resect these. Okay, and they do get they get lots of infections because they're full of mucus. Next thing you may see is airway foreign bodies. Most common is still peanuts. Most common location is still the right main stem bronchus. The workup for these things is now a CAT scan. Used to be just X-ray for post-obstructive atelectasis, which had turned into a lot, history in the X-ray, got a lot of negative bronchoscopy. Now with CT scan, very sensitive with small slice CT scans, non-contrast, can even see, you can see radiopaque ones easily. You can see non-radiopaque. You can actually see a lot, even a peanut, and see the outline of the peanut on the CAT scan. So review pulmonary lesions, congenital lobar emphysema, usually upper lobes, intrinsic bronchial obstruction, looks like a tension pneumothorax. The treatment is excision of the affected lobe. CPAMs, cystic proliferation in terminal airways, the risk of infection or cancer, elective resection in 3 to 6 months. Sequestration, just essentially abnormal lung tissue does not connect to the tracheobronchial tree of the pulmonary arteries. Systemic arterial supply, risk is commonly infection, not associated with cancer or pleural, but elective resection. Bronchogenic cyst, hamartoma of the bronchial tree. You can get extrinsic obstruction of the airways and infection. You resect these also. Nope, sorry, I did that twice. Now we're in esophagus. Esophagus, we'll start with foreign bodies. Most common object is a coin, small toy parts. They often get stuck in 3 anatomic areas narrowing in the natural esophagus. The cricopharyngeus is the most common, midway in the esophagus at the aortic arch where the aortic arch crosses over, and then the GE junction. If a foreign body gets into the stomach and it's not a foreign body that you're worried about for whatever reason, it will pass. Okay. Disc button batteries are getting a lot of press. And actually, on my CME this year, there's been at least 3 questions about disc button batteries. If the disc button battery is in the esophagus, it is a surgical emergency. It can erode through the esophagus in a few hours, and I've seen it. The new thing is if they're going or being transferred to a peds hospital, if you give them honey and just tell them to take a teaspoon of honey every 10 minutes or so to coat the battery, it stops the conduction of the battery and stops the burning. You can't give honey if they're less than a year of age, so you use Carafate if they're less than a year of age. But the disc battery is an emergency. Just different pictures of different foreign bodies, a personal level lens lamp. I took out a airway foreign body last month that was an earring that was shaped like a lightning bolt. That was fun. So next thing, you get corrosive injury of the esophagus. It's usually a basic injury. So the esophagus is used to seeing acids, not so used to seeing base. So kids will ingest lye. The treatment for that is you want to irrigate, wash it out. There is some data out there that if you do gentle acetic acid, you can stop the burn from the lye, but usually they're too far out from the injury that will make a difference. Steroids have been not shown to be very good, but you want to keep them NPO and you want to watch them. They will develop, if they don't perforate, they will probably develop a stricture later, which you'll have to deal with serial dilations. Now, this is a full-term newborn who was not respiratory. The vignette will be full-term newborn in respiratory distress after feeds. Not born with respiratory distress, but doing fine until they try and feed. And there's going to be a tube tried to get stopped. It just stops. It loops. and then it's going to have either, and then it should have a two, but it's got die. This is a proximal parotid, and then this has got an air-filled stomach, and this has no stomach. So these are the two things you're going to see. Tracheoesophageal fistula with esophageal atresia. 5 types. Type C, common, proximal pouch, distal fistula. So you got a NG tube or OG tube that's coiled that can't go down, and you still got distal gastric air because they're swallowing air. Instead of swallowing air, they're inhaling air that's going through that fistula. The second most common one is pure atresia. The tube doesn't advance, but there's no distal air. That's the one you're going to see. And then the third one that you're going to see sometimes is an H-type fistula. So the esophagus is intact, trachea is intact, but there's a communication. This is the one where the kid will have, the vignette will be about a 1-year-old with multiple episodes of pneumonias, and now has an upper GI or has a endoscopy, which shows, or they'll say it has a bronchoscopy, which shows evidence of bile in the trachea, or something. Will give you some kind of hint that there is a connection between the esophagus and the trachea. So that's a type E. Type C, most common. You confirm the diagnosis with a rigid bronchoscopy. Down here's the carina. Here's the fistula. Fistula is usually above the carina. That's a good sign. That means your distal esophagus is up pretty high, hopefully pretty close to the blind upper pouch, so you can ligate this and get them back together again. You decompress the upper pouch as your first part. You elevate the head of the bed. You put them on reflux precautions because they can aspirate their own saliva, which you don't want them to do. You don't want to positive pressure ventilate these kids before you operate, because the positive pressure will preferentially go through the fistula as opposed to the pulmonary tree because of the least resistance through the GI tract. The repair is ligate the fistula and do a primary anastomosis you can. Now, more and more, a lot of people are doing them with video assisted with VATS. You still can do them open. It is not wrong. But, if you read most of the papers, they'll be doing a VATS. One of the comments as to why you would do VATS versus open is that there is a perceived risk of scoliosis with open thoracotomies. And there is an increased risk of scoliosis in babies who had thoracotomies. It is not, some people estimate as high as 25% of thoracotomies. That's the major reason why we're trying to do more with VATS instead of open thoracotomies. But the leak rate with a VATS TF repair is actually measured higher than the leak rate for open. So keep that in mind. You want to be able to do an operation as safely as you can. Long-term complications of TF will come up. They can have an esophageal stricture, which can have scarring of the anastomosis from either tension in the anastomosis or they had a leak. But they also all have GERD because you actually decrease the amount of intra-abdominal esophagus when you pull up the distal. So they'll have reflux. They now have a higher rate of Barrett's esophagus. This may be a new question. Kids with TEF now have to be now recommended to have surveillance endoscopy for life, and they have up to a 10 to 15% risk of Barrett's esophagus. And that's something you want to diagnose early. They can have recurrent TF, but that's rare. GERD, we talked about, they all have poor to non-existent esophageal motility. Their lower esophageal sphincter is not developed well. So you stretch their distal stomach, the distal esophagus to bring it up so they can have this decreased intra-abdominal esophagus. And so you want to keep that in mind because there's bad esophageal motility. You really don't want to do a NIS unless you absolutely have to. And they all have tracheomalacia. This is due to the fistula being attached to the bronchus, and there's a soft spot. So they have a barking cough, which they do grow out of as their trachea gets bigger. Good time as any to bring up Voxeral syndrome. Everybody loves this sometime during your test days. The associated anomalies with any of these all come up. So Voxeral, vertebral anomalies, either they're missing vertebra or they have hypertrophy of some of the lumbar sacral spine. Anal rectal malformations, most commonly in perforate anus. 20% of cardiac anomalies. TEF, renal anomalies. They can have horseshoe kidney. They can have a single kidney, they have no kidneys, and radial limb hypoplasia. So by definition, if you have one of these problems, you have just that problem. If you have two or more of these, you are associated with Voxeral syndrome. It's a syndrome, it's just an association. There's no known genetic problem that we know about causing this. Well, we haven't figured that out yet. Keep going down the chest. Congenital chest wall anomalies, pectus excavatum, pectus carinatum. If you see a chest wall anomaly, the question is usually going to be what it's associated with. Just think about collagen issues, Marfan's, Ehlers-Danlos, and scoliosis. So Marfan's is the big one that they'll give you this real big, tall kid with a sunken chest, and you hear a murmur. So you got to work him up for Marfan's. We used to do early open surgery. We used to do early open surgery. Now, if you operate on these kids early, your only option is open surgery, which resect all the deformed cartilages and either pop up or pop down the sternum. It is associated with a lot of pain, a lot of recurrence, and a lot of other issues. So we tend not to do these anymore. For the pectus excavatum now, we do a NUS repair. If you affectionately just go in, you thoracoscopically watch, make a plane between the sternum that's sunken in and the pericardium, and then you work a bar across that, and then you literally flip the bar to try and pop the dent. Leave the bar in for at least 2 years. Some people say 2, some people say 3, and then you remove it. We do this under thoracoscopic guidance, and the new thing is that we had cryotherapy now for pain control. You actually freeze the rib heads from T3 to T8, and you give the entire chest wall about 3 months of numbness until the axons regrow. 10% incidence of persistent pain and persistent paresthesias with this. There is now a thing called suction belt system for a non-op repair of pectus. You have to do this earlier and for very decreased defects. You'll already there's a suction system to actually try and suck out the chest in smaller kids. Pectus carinatum surgery has been mostly replaced by brace therapy. You put a brace on, they get these things made in prosthetics lab. You get continued pressure. The original protocol is 23 hours a day for 2 to 3 months. Those kids won't wear it that long, so I tell them to wear it 12 to 14 hours a day for a year, and it usually gets much better compliance. Moving on to the abdomen. All right, I'm making bad time. And we're up to a whopping 13 people. Cool. All right, when you think about abdomen, I always want you to think about when the questions are describing stuff to you, where is the lesion? And is it going to be a physical problem or a functional problem or a combination of both? And then we're going to do this by age. So newborn is sometimes either fed a past meconium or they start vomiting green stuff. And say, think about what's going on. Is the lumen or the pipe clogged, occluded, narrowed, or not there? Or it just doesn't work? So we're going to start at the top. Double bubble. Newborn, not going to be in respiratory distress, not going to be sick, going to just be vomiting and double bubble. All this pectory tells you is that it's a proximal obstruction. A double bubble is historically associated with duodenal atresia. It can be bilious, it can be non-bilious. This is basically any proximal obstruction. You can have a malrotation with a partial, usually you can have annular pancreas, you can have a duodenal atresia, or you can have a midgut volvulus being caused by a malrotation. If you think about this, the top 3 of these are not sick. The bottom kid is sick. It's got malrotation, but now they volvulized, they're going to be sick. So if you have duodenal atresia, you got to think about midgut volvulus. If you don't know this prenatally. They could have had a prenat. And it didn't show itself up for a couple of days. You really got to think about malrotation. It's usually picked up on prenatal ultrasound if it's duodenal atresia, and they usually have polyhydramnios. If you're thinking about whether a mom has poly or oligohydramnios, polyhydramnio associated with GI, so pig. Poly is GI, oligo is renal. So 85% of the duodenal atresia will present with bilious vomiting because this duodenal atresia is usually distal to the sphincter of Oddi. So you're treating it, you do a duodenostomy. This is the diamond-shaped repair. Now we're doing most of these laparoscopically too. Survival rates with duodenal atresia alone is greater than 90%. Duodenal atresia has a association with Downs, and also duodenal atresia, since it is associated with Downs, there is a small associated with cardiac defects. If you have duodenal atresia and Downs, you got a higher risk of a cardiac defect. Now, another patient, this is a more still a proximal obstruction, but not duodenal. Kid's not sick, so they got a contrast image. So if you get a kid who's got microcolon and small bowel dilatation, so these are just dilated loops. You don't know whether they're small, large bowel, but the colon study here shows you that the colon is tiny. That's usually an intestinal atresia. We talked about duodenal. Jejunal ileal, you have more distal gas, and again, not sick. Colonic is a more delayed presentation. What do you think about it? If air and food got to get down there? Atresia can even include, in the pure sense of the word, an imperforate anus. You have an atresia of the anus. So that's where, we'll talk about each one of these. Intestinal atresia is thought to be caused by vascular accidents in the mesentery, leading to segmental loss of the intestinal lumen and ischemia in utero. They don't get sick because they basically just involute and seal, and there's no flora, so there's no infection from a leak. Surgical treatment is at least urgent, meaning that you don't want you want them to get through the trauma of being born, transition, and then operate. There's 4 different types, which is rarely asked on your ABSITEs and more ped surgery ABSITEs, but type 1 is basically, it looks like a congenital stricture. Type 2 is atretic. Type 3B is an apple peel, where the entire small bowel is on a single SMA band. It doesn't have it's kind of corkscrewed around the SMA with not very much arborization. Type 4 is multiple. So this is an ileal atresia. This is one that the kid had a focal volvulus after birth because, it's a little bit ischemic. This is what you took out. This is obviously proximally dilated. What do you do? Here's actually the appendix. Here's the distal ileum. There's the valve. The question is, do I want to save the valve there? It's within 2 centimeters of the valve, so the answer is no. I resected back up to about here, probably, because that little loop would probably worry me with ischemia, and attach this to the colon. There's the anastomosis. You can have intestinal duplications, which are cystic structures, but that share a muscular wall. These are really present as extrinsic compression issues and are sometimes harder to diagnose. You resect the cyst, try and save the blood supply of the underlying bowel. If you can't, then you just do a resection and anastomosis. This is more distal cause of obstruction. You don't know where it is by the plain films. You just know it's not, it looks pretty distal. You still don't know if it's small or large bowel. This little mass effect here on the left x-ray with the arrows gives you a hint. But, distal bowel obstruction, you can still have ileal atresia, distal atresias. You can have colonic atresia. You can have small F colon syndrome, or you can have Hirschsprung's. But the things we're going to talk about is meconium disease. Meconium plug versus meconium ileus. Meconium disease is the fact that you can have meconium is very thick, tenacious sink first bowel movement. If your baby is somewhat underhydrated and the meconium inspissates into the large intestine and it can't be passed, that's meconium plugs. You do a water soluble contrast, they get a whole bunch of plugs in the colon, and then the baby defecates and you cure them. It is not associated with cystic fibrosis. Water soluble contrast is curative, but you do have to worry about Hirschsprung's disease with meconium plugs. So meconium plug can't help with the name. Meconium plugs are colon, and you have to worry about Hirschsprung's. Meconium ileus is obstruction of the terminal ileum because the meconium is so thick it can't get through the valve. That is almost uniformly associated with cystic fibrosis and is different than meconium plug, even though it's a very similar name. So meconium ileus can lead to high-grade obstruction associated with cystic fibrosis. The treatment is either simple, if you can do a water-soluble contrast enema, reflux past the ileocecal valve, solubilize the plugs, and then you can pass them, then you're fine. That's simple ileus. If the contrast fails, then it becomes, by definition, complicated, and you have to go to surgery. You can do mucomist or you can do water-soluble contrast to relieve it. So meconium ileus, all these plugs in the terminal ileum. Simple as that, someone does a water-soluble contrast enema, it comes out, it solubilizes all this stuff, and they pass. Complicated can be this anatomy that you just can't get to it, and you have to go in and sometimes use the appendix and put a catheter in. Sometimes you just stick a little needle tangentially through and instill mucomist or contrast and kind of milk it back and forth to get it out. Other times you got to do a resection or at least an opening of stuff that's overdilated. Because of this big mass of meconium, they can have an atresia if it flopped over in utero. They can have a volvulus, or they can have a perforation. If they perforate perinatally, meaning if they perforate right before birth and that causes distress to the kid, or they perforate after birth, that is the most complicated meconium ileus, which is called meconium peritonitis. So meconium peritonitis is with perforation and sepsis. It's a different kid, really distended, newborn after a couple of days. X-rays of that kid or a kid similar show distal air obstruction. Really can't tell, again, small and large bowel. Remember, in babies, you can't tell small and large bowel because they don't have haustra in the large bowel. But if you're looking at this a whole bunch here, you can say, well, that probably is colon and rectum, but I can't be sure. So you get an enema. These kids are distended but not sick. Now this enema, you got this big dilated sigmoid tapers into a rectum that is not dilating. That is a transition zone from dilated proximal to decompressed distal, which you really shouldn't have. Your rectum should be the biggest piece, and that is diagnosis. This is pathognomonic for Hirschsprung's disease. Another one just saying that this is probably more proximal transition zone all the way up by the splenic flexure. This is a nice old picture of, a transition zone on enema and then a clinical transition zone here to here. So Hirschsprung's disease, a dilated hypertrophy colon proximal to the abnormal rectum. Symptoms are constipation, abdominal distension, and or colitis. 1 in 5,000 births associated with the Rett proto-oncogene, 80% male. If you're more likely to have this if you're male, but if you're a female, you're more likely to have a worse outcome or a worse, longer segment. It does, again, since it's on an oncogene, it does run in families and is, again, as we said earlier, associated with Down syndrome. So premature and other associated anomalies are uncommon. There can be some urologic things, sometimes that can have a megaureter, but rarely. Usually Hirschsprung's disease is on its own unless you have Downs. You suspect it clinically, they're not passing meconium within the first 24 to 48 hours, or they're not passing stool very regularly, and they have a normal anatomy on exam. The treatment, you have to get a lower GI to look at a transition zone. We now get the lower GIs earlier and earlier, so it's harder to get the transition zone because it hasn't developed yet. but you have to confirm it with biopsy. The biopsy is a negative study. You do a suction rectal biopsy, which is a small little piece of the mucosa and the submucosa, and it's absence of the ganglion cells in the submucosa. The new thing that we do that is now calretin staining, calretinon. Calretin staining. If calretin staining is positive, they do not have Hirschsprung's disease. That is, it picks up the nerve fibers. Hirschsprung's enterocolitis is because they have lots of stasis. Just think about anything, pouchitis, anything causes stasis, causes bacterial overgrowth, and can be lethal and can even occur after we repair them. There's 3 different options: the Swenson, the Duhamel, and the Suave. The Swenson is basically an APR, right above the dentate line, full thickness, right in, take out the rectum, and reanastomose right at the dentate line, right proximal to it. The Duhamel is you leave a pouch, like a Hardman's pouch, and then you do a side-to-side anastomosis, usually with a stapler. So the problem is now you have this pouch that still has an agangliotic segment and good stuff. You're supposed to let the staple line go all the way up here. The hard part about that is this has a higher rate of pouchitis or enterocolitis because of the stasis. And then the Suave is you do a mucosal dissection for 2 centimeters before you make it full thickness. So you leave the rectal wall intact and just scrape out the mucosa, kind of like a iliopouch anal anastomosis that they'll do. This is supposed to be better for long term because the parasympathetics and sympathetics of the pelvis go through this musculature. So less issues with retrograde ejaculation later in life for the boys, less issues later on. But if you think about this one has the highest rate of constipation because you got 4 muscle layers instead of 2. So this one has the highest rate of constipation. This one has the highest rate of enterocolitis. This one has the highest rate of incontinence because you're cutting right, unless you really hug that, you can screw up the nerve endings to the levators and the extrinsic external sphincter. Neck is the next thing. Necrotizing enterocolitis. It is infection, started with infection and ischemia. Who knows what comes first? You lose mucosal barriers. Bacteria migrate through the bowel wall. Anaerobic bacteria win. So you get pneumatosis, which is air in the bowel wall. Eventually, if you let it go unchecked, you get portal venous air as those anaerobic bacteria travel up through the SMV and get in the portal vein and then invade the liver. So risk factors for premature, enteral feeding. People argue what type of food is, if you're eating feeding formula as opposed to feeding breast milk, you're at higher risk. If you're feeding higher osmolality, that's a higher risk. If you're feeding different fortifiers, they have higher risk. Mucosal injury, they think mucosal injury is first, but who knows? How do you treat it? You discontinue feeds. You place an NG tube, you start on broad spectrum antibiotics, and you resuscitate. Basically, this is intra-abdominal sepsis. You don't operate unless you have to. There's 3 different stages. Stage 1 is they're sick, but they're not ill. Stage 2 is they're requiring active resuscitation, sometimes need ventilation, sometimes need pressors. Stage 3 is you have intestinal perforation, which is treated with, basically, damage control laparotomy. You operate, you resect anything that's obviously dead, and come back and you either bring out a stoma or come back and bring out a stoma and do anastomosis much later. You don't do an anastomosis in these kids that are sick. So surgery is the last resort. If you're less than 800 grams and you've perforated, you can treat this or at least temporize this with a bedside abdominal drain. Kind of like, if you think about a damage control laparotomy in trauma or in, intra-abdominal sepsis, this is essentially the same thing, just you're not looking and you're making 1 hole or 2 little holes, you irrigate and leaving the drain in. Basically an open abdomen. Survival depends on stage. Higher the stage, lower the survival. You can sometimes make these kids short gut if you'll take out too much intestine, but really whatever test you take out is really not up to you. It's up to the disease. And obviously, if you're less than a kilo when you start this process, you have a higher rate of mortality. On to imperforate anus. Part of the Doctoral Association. I had a whole bunch of pictures I took out. We're just going to do the highlights. If you're a physical examined male, you have a imperforate anus, you're more likely to have a high anomaly, meaning that your colon did not make it anywhere near the anal verge, and it's usually at the prostate. So there's usually a rectoprostatic fistula, and you're most likely to need a 3-stage repair. The first stage is a colostomy, the second stage is a repair, and after that heals, the third phase is reverse the colostomy over the course of the first year of life. So you inspect, you make sure there's no other lethal associated defects, you make sure the whole baby looks okay, and you look for a fistula. And you don't, if you see this, if someone picks this up on the first day of life, you actually wait 24 hours and let air go down and see if you can see a fistula developing. If you see a fistula, you can do a minor imperforate anus repair called an anoplasty. But if not, if you see gas below the coccyx, there's a special thing called an invertogram, and I'll show you that. This is what an invertogram looks like. You wait 24 hours, you stick the baby butt up in the air, you wait about 10 minutes, you put a little marker where you think the anal opening should be, and you get a picture. If the air column was within 2 centimeters of the marker, that means you probably can do a primary approach and go find it and take it, and it's close enough that you can do a primary repair and not do a diverting ostomy. But if it is farther than that, or you don't feel comfortable, an ostomy is always right. Females, not males, are more likely to have a low anomaly called a rectovestibular fistula. They may have the worst thing they can have is a single orifice called a cloaca. So in girls, you do an inspection. If they have a single orifice that has all 3 holes, vaginal opening, urethra, and anus in one hole, that's a cloaca. That is definitely needs a diverting colostomy and go operate later after they grow. This is associated with high issues with the uterus, and you can have a hydrocolpos, and you have a lot of other issues that you got to look at when you're doing your colostomy. Perineal fistula or vestibular fistula. Perineal fistula means there's any amount of perineal body between the base of the vagina and the opening. Vestibular fistula means that the base of the vaginal opening, the posterior vaginal opening, and the anterior anal opening share a wall. Those can get dilated so they can poop, and then you can let them grow for 6 to 8 weeks and then come back and fix them, or you can do a primary repair too. I prefer to wait so that the dissection between those 2 planes is a little easier. Data shows that they both do well. You can also do the same cross-table lateral film. Girls, you do a boy if you don't have a fistula or any evidence of meconium in the perineum after 24 hours, and give them a stoma if you need. All right, when you do the diverting colostomies, it's probably not for ABSITE, but just to teach you guys, if you think about it, if you're doing a diverting colostomy, you're leaving a Hartman's pouch. You're actually going to bring out a mucus fistula. And you're going to bring out a mucus fistula so that you can study this distal limb to see where the end of the rectum attaches to. In a boy, it's most likely to be the prostate, but it could be the bladder. It could be a little lower, but you want to know. And when you divide this stoma, you want to make sure that this distal length is enough to bring down to give him a new butt at some point. So a lot of us will define as you put in, and this is all dilated, it's hard to find, you put in, bring out the loop, and you see where the original attachments to the white line had told us. You take a couple of, then you're making your division, and you're leaving the entire sigmoid colon to do your repair, and it's a nice transition for blood supply, and this comes up as a nice little stoma in the distal left colon, and it makes it easier later if this distance, you have to bring a lot of this stuff down, and it gives you enough distance to bring down into your anastomosis, your 3rd stage. That's what a fistulogram can look like. It doesn't really look really great. This is it's coming through the mucus fistula. Here's going into the distal right there, and it's coming out it's actually coming out the penis there, so it's coming out. That's a prostatic fistula. The second stage, when you repair it, you do a posterior approach. It's called a PSARP, a posterior sagittal anal rectoplasty. You'll divide the perineum from the fistula site all the way down. And a high variance, you can take it all the way up to the coccyx. Sometimes you have to resect the coccyx to get the distal limb down. You map the sphincters with a stimulator, a nerve stimulator, and leave stitches in to show those in. So that's where you bring the new rectum down and bring it out through the bottom. And now the higher the anomaly, if your anomaly is intraperitoneal as opposed to extraperitoneal below the peritoneal reflection, then you can do them laparoscopically. Doesn't make sense to do it laparoscopically if it's a distal enough anomaly that you don't need to enter the abdomen. All right. I'm going to keep going. What cause? These are going to be other older patients' cause of obstruction. This is something that says 7-day to 1-year-old boy, meaning that the age that they're going to give you this presentation is not going to be in the newborn period usually, but it can be anywhere from a week or two old all the way up to a year old's most common times they're going to present this, okay? This is a patient who's got bilious vomiting who's going to be presented as being ill. Was doing well, then started barfing, he barfed more, and now the baby's kind of lethargic, mottled, and has a high heart rate. Plain films are going to show either gasless abdomen, which is much more worrisome than a gas-filled abdomen, or proximal obstruction. This doesn't look much different than that jejunal atresia picture. The difference is this kid is not a newborn. It's about the first day or two of life, and now they're sick. So this is going to be the presentation for malrotation with midgut volvulus. This is an upper GI just showing a corkscrew, a couple more upper GIs. This is an upper GI with a corkscrew, the duodenum, and a blockage. This is an upper GI showing a malro, probably doesn't actively have a volvulus at the time of the film because it's not obstructed. So, but bilious vomiting in a sick patient in a newborn is malrotation with midgut volvulus until proven otherwise. Honestly, they should ask you this every couple of years because it's something you can't miss no matter where you are in your life if you're a surgeon. It's due to abnormal rotation and fixation. 50% of children present with symptoms in the first month of life, and 80% present in the first year of life. So that's what I'm going to say. The vignette's going to be somewhere between 2 years and 2 months, 2 weeks, and a year old. Abdomen may be scaphoid because originally it starts out as, it's a proximal obstruction. So they're throwing up and there's no distal air. But then they get worse because as the thing is twisted and they get ischemic, then they start third space and get sick and get obtunded. You wait too long, bowel dies. Okay. So again, I always say when we talk about this in small groups, this is the baby equivalent of an SMA thrombus. Same idea. Instead of thrombosing the SMA, you've twisted and occluded the SMA with a twist. Upper GI is the best test for malrotation for the anatomy. The duodenojejunal junction, a ligament or trite, should be to the left of the midline, level with or superior to the pylorus, and posterior. So if you're doing these not at a children's hospital, you got to tell them to make sure they get a lateral film because you can't see whether they're posterior or not without the lateral film. A barrier is suggestive, but it cannot rule out malro. Ultrasound is now getting more and more popular because now it isn't good to show malro, but it is good to show volvulus because they can find the SMA, and if they find swirling flow in it or no flow in it, they know something's obstructed. So how does that happen? When you have malrotation, if you have normal rotation, your SMA goes from ligament trites to the terminal ileum. It's got the middle colic artery. So basically this SMA distribution is nice and wide, lots of arborization. If you have malro, the SMA goes straight down. It's blocked from going, this duodenum is blocked from going up here because of these LADS bands. And now the SMA doesn't branch off till later, so the entire small intestine is on this one branch and can easily flip on itself, and it rotates clockwise. Last procedure, if you're doing last procedure for midgut volvulus, you were not doing this laparoscopically. You were doing it open because time is of the essence, and you got to untwist this big intestinal mass that's ischemic. You take down the ligament, the Ladd's bands, and then you try and move the cecum as far left as possible to try and widen this narrow mesentery. And then the appendix lives over here. And traditionally, Ladd's procedure still says take the appendix out. This is a real one. This is the volvulus. This is the twist. Okay. Here's the Ladd's bands that look kind of thick there. Once it's untwisted, you can see actually pinking up. Here's the appendix. I'm about to take out the appendix. And then once I get everything situated, here's the appendiceal stump. This is that widened mesentery. And then here's all the small intestine on one side. This is the colon on the other. The kid's head's up here. It's a little upside down. The kid's head's here. The kid's there. So we're going from there. And we tried to divide everything, and now it all pinked up, and now that's what it looks like. Trying to fit this in. This is really not obstruction, but it's a problem that comes up some ways. Pediatrician tells you he's got a 21-day-old who's persistently jaundiced, and white stools. So jaundice and white stools. So we got you have a biliary obstruction. So acolic stools in the adult world, you're really thinking pancreatic or biliary cholangiocarcinoma. And here you're thinking something called biliary atresia. Biliary atresia is an obstruction of the extrahepatic biliary system that develops quickly at birth. There are two types. There's a fetal embryonic form that is in the first 2 weeks of life, and then there's a postnatal form where sometimes these kids will even have bilious stools for a couple of days and they gradually get lighter, as opposed to they're born and have white stools from the beginning. We think it's a post-infectious, it's an autoimmune phenomenon that we still don't know the answers quite yet, but it is definitely an autoimmune stricturing of the biliary tree, kind of like primary sclerosing cholangitis. So the biliary system is here. This is really rudimentary, but just here to remind me, you get scar all the way up the biliary tree, and it can scar even into the liver. It gets it gets obliterated, and if you don't operate on it quick enough, the entire liver will die. So what else can mimic this? What gives you persistent direct hyperbilirubinemia in newborn? CMV, HIV, alpha-1 antitrypsin deficiency, something called Alagille syndrome. These are the lab tests you get. MMP7 is the new lab that is diagnostic for biliary atresia. MMP7 is elevated. You have biliary atresia. Ultrasound, you look for the gallbladder. HIDA scan with or without phenobarbital load, meaning the phenobarbital will make the gallbladder, the liver secrete more bile, so you get a better study. If you do find a gallbladder, but you're still persistently hyperbilirubinemia and all this stuff is negative, you can do a cholangiogram, a liver biopsy, and look for other reasons. IR loves to say they can do cholangiograms. Easier said than done. The operation is a diagnostic laparoscopy. Look for a gallbladder. If the gallbladder's there, you try and do a cholangiogram. If you can do a cholangiogram, great. If you can't do a cholangiogram, then you got to do something called a Kasai procedure. Kasai procedure, the earlier you do it, the better the outcomes. You want to be, less than 60 days is the best time. You do a Roux-en-Y anastomosis you take out the entire extrahepatic biliary tree, and you sew the Roux limb up to what's called the portal plate. You dissect all the way up to above the bifurcation of the right and left hepatic ducts, right there, and that's where you sew to. Usually it's a real just sclerosed band, and how do you know? You actually just follow the portal vein up, and when the portal vein bisects, that's where you look for your portal plate. If the procedure goes perfect with no issues with technical issues, 1/3 still fail right away. 1/3 will function short term, meaning like work for about a year, and 1/3 will function long term. So 2/3 of these kids eventually need a transplant. If there's evidence of liver necrosis when you go in and look, you don't do a Kasai because it's not going to help the kid. The kid needs a liver transplant, and don't mess up the anatomy for the transplanter. Long-term survivors, when any rule into the biliary tree, you have a long-term risk of cholangitis. Choledochal cysts are the other thing that they love to ask about, I should say. There are 5 types of choledochal cysts. Choledochal cysts usually presents with, again, jaundice. Now, an ultrasound shows dilation as opposed to stricture. These can happen later. They don't have to happen in the newborn period. Most common time I've seen these is in the toddler stage. There's an otherwise healthy 2-year-old kid all of a sudden has jaundice. They get an ultrasound and they see a cyst. Type 1 is just extrahepatic biliary tree cystic dilation. Type 2, just think 2 is 2 gallbladders. Type 3 is a choledococele. That's when you can see in adults, and you see these things more in adults. Type 4 is both intrahepatic and extrahepatic. So that's, and then type 5 is just intrahepatic, which is Caroli's disease that needs liver transplant. That's the only answer for this. So just have intrahepatic dilation and normal extrahepatic, that's Caroli's disease. Type 4 is both. Type 1 is just that. The operation is the same for type 1, type 2, and type 3. I'm sorry, type 4. Type 3 is you gotta just resect the cyst, trying to not upset the sphincter. And you usually don't do, if you can just get the cyst out and keep the sphincter open, you're okay. These are all need a Roux-en-Y and anastomosis. Now we're done liver, we're done benign liver, we're done neonatal cause obstruction, and now we're going to go to infant. Pyloric stenosis is this is going to be the 1 month to 6-week-old kid who comes in with non-bilious vomiting who is not febrile. So non-bilious vomiting, 4 weeks to 8 weeks gestational age. 4 weeks to 8 weeks old, who's got non-bilious vomiting, which is, they'll say projectile. Sometimes they will, sometimes they won't. So you got a gastric outlet obstruction. As a gastric outlet obstruction, they love to ask these questions. They get dehydrated. They get hypochloremic, hypokalemic alkalosis. You have to correct that alkalosis before you go to the operating room because you compensate for a metabolic alkalosis with a respiratory acidosis, so they have decreased ability to breathe. And if you put them to sleep before you correct the metabolic alkalosis, they don't wake up because their drive to breathe is gone. They get paradoxical aciduria because they're so dehydrated and their sodium potassium pumps are depleted because they get hypokalemic. And then their sodium hydrogen pumps kick in to try and conserve more water, so they get paradoxical aciduria. Physical exam, if they're sick enough and they're lethargic enough, you can palpate an olive. I always try and palpate an olive once they're asleep and relaxed just to double check. Radiology, the test of choice is an ultrasound. You're looking for channel length and width. And now they're also doing test feeds to look to make sure nothing's going through the pyloric channel while they've got the ultrasound probe right on the pyloric channel. An upper GI can still be done. You get a string sign or a shoulder sign. If you do an upper GI, just make sure you're suctioning it out. So you get hypertrophy without hyperplasia. The etiology is really unknown, but it's definitely inflammatory. It's probably post-infectious. So again, 2 weeks to 2 months of age. A lot of times these kids are being treated for reflux. They're being treated for, formula intolerance, but really this is slowly developing. Depending on how dehydrated you are and how much alkalosis you have, it depends on how many boluses you're going to need. So if your chloride less than 85, we give 320 per kilo fluid boluses before we recheck their lights. This is a cool paper where actually somebody looked to see how many boluses kids need before the electrolytes were fixed. And so now we just empirically do it before we check them again, so we save them from pokes. Their abdomen is usually scaphoid, unless they're, after they've thrown up. They fill up with air, they barf in their abdomen because they got a proximal obstruction. We talk about their imaging. Ultrasound is first line. Here's your thickness. It's a really good picture. You operate, you do it laparoscopically. 3 people still do it open. You put a camera in the belly button and you put 2 little poke holes. You hold the pelvic muscle steady on one side. You cut the top layer and you spread the bottom layer until you see mucosa bulging. You can see this nice shoulder. You can see there. The problem is laparoscopically, they have a higher rate of perforation. And so that's one of the arguments to still do them open. But majority of people my generation and younger are doing them all laparoscopically. Okay. Now, the other thing we learned when we started doing this with the cameras is that you can feed the kids earlier. We used to make them wait and do a bunch of feeding regimens. Now they just feed immediately. And whether you do them open or laparoscopic, they can feed early. Reflux. Reflux occurs to some degree in everybody. Every baby's got reflux. That's why you have burp bibs. It has reflux, becomes reflux disease when you manifest something bad because of the reflux. So if you have failure to thrive, you have recurrent upper respiratory infections, you have bad reactive airway disease from microaspiration. That means you have gastroesophageal reflux disease. First steps are what most of you guys are parents already know. You thicken the formula, you burp them a lot, you feed them a little smaller frequent feeds, and you go from there. Then you treat them with medicines. You can treat them with proton pump inhibitors or H2 blockers. Lots of stuff in the PEES literature. What's good, what should and we shouldn't use first, and we go from there. Reglan is a good stomach emptier. If you have a gastric outlet obstruction or relative pelvic spasm or pelvic stenosis, you obviously will make it worse. Reglan, you got to worry about the side effects of Reglan, which some come up with the test is tardive dyskinesia, and that's a bad thing. It doesn't go away. So some pediatricians are afraid of Reglan. Surgery is rarely needed in a non-neurologically impaired child. Nissen fundoplication is really now reserved for true complications, strictures of horrible reflux disease. We used to do them a lot more of these, just like the adult guys did, and they've gone out of favor because we realized we're doing an operation on people who didn't need it. Lots of recurrent reflux even after wraps. Lots of failure of the wraps. Lots of paraesophageal hernias after wraps. So we don't do them. But if you do have to do them, we do Nissens. We do a posterior 360-degree wrap. I do pledgets on mine because as the kid grows, this is going to try and stretch. The part of the operation that reduces the reflux is not the wrap at all, which is why they're doors, thals, toupees, all these different wraps, Nissens. The operation is increasing the length of the intra-abdominal esophagus, and then the wrap just keeps it there. Another one this is a common scenario they'll put on the ABSITE is a 9-month-old. It's usually going to be a toddler. Presents with severe cramping abdominal pain. This is the one that clinically presents the way it does supposed to in the textbook. Going to tell you it's that, about a 12 to 18 hour history of the kid progressively just maybe they're vomiting, maybe they're not, but they double over in pain about every 20 minutes and they're inconsolable. And then they're fine after that bout, and then they're inconsolable. Then they're fine, and over the course of several hours, instead of being fine in between, they start to get lethargic and they start to get really tired. It's because they're getting sicker and sicker. All right. This is the one where you go to the ER, they say the kid's got excruciating pain. You go in and the kid's fine. So intussusception, episodes of unconsolable abdominal pain intermixed with episodes of lethargy. Okay. 6 to 18 months, male equals female. It's associated with recent infection, either upper respiratory or enteritis, something that makes their lymph nodes in their entire body go inflamed. Intussusception is an infolding of the intestine inside each other. You can have this happen anywhere in the GI tract. Small bowel intussusceptions are very common in almost everybody who's got, dehydration. The hard part is that when you have an ileocolic one where it intussuscepts into the ileocecal valve, then the valve prevents it from spontaneously reducing. Okay. The current jelly stools are the historical thing that may or may not be on the presentation. If you hear current jelly stools, they're probably just giving you a hint that it's intussusception, but in practice, if you have current jelly stools, it's probably further along because that's caused by ischemia and sloughing of the mucosa. So more than 80% of the ones that require intervention are ileocolic. The other 20% are persistent small bowel intussusceptions, or large bowel intussusceptions that are caused by something from some other pathology. Anatomic lead point can be anywhere from 2 to 12%, but after age 4, so if you see an intussusception in a vignette where someone is in the 7 to 8-year-old range, they're probably giving you a hint that they have something else going on and are an absite bet lymphoma. But benign causes of ileocolic intussusceptions that don't reduce on their own, Meckel's diverticulum can cause it. Appendicitis can cause it. Polyps, carcinoids, hemorrhage, Putz-Jaeger's disease. Anything that can cause thickening of the submucosa that then the peristaltic wave can pick it up and invaginate it as it's going around. If you have a small bowel intussusception in a bigger kid, that's probably lymphoma. The most common lymphoma in the small bowel in a kid is a Burkitt's lymphoma. So how do you treat intussusception? You do enemas. We more than likely use air now, not water-soluble contrast, but the water-soluble contrast gives you better pictures for lectures. You literally put a tube in the kid's rectum, you tape the kid's butt shut, and then you hook it up to a blood pressure cuff with a pressure gauge on it, and you fill up the underfloor, you fill up the rectum with air, and you watch the air column go, and you try and put a steady column of pressure of 120 millimeters of mercury, and you try and pop it open. If you can't do it, you got to go to the OR and do it. This is obviously an intraoperative film of something that wasn't able to be reduced. Do you reduce them? You try and manually reduce them, you just resect, which I try and manually reduce them. I mean, if I partially reduce it, I can take out less bowel. You can do this laparoscopically. You can do it open. Talk about not pulling on the bowel if you're reducing it, but if you're doing laparoscopically, you have to. Should not take the appendix out. In its inception, there is some data out there that if you do a surgical reduction of intussusception, you're successfully reducing the intussusception. That's all you should do. Could you take the appendix out in that setting? There's a higher complication rate. Next one is a 7-year-old with abdominal pain. This is going to be what do you do for any other kid that comes in your abdominal pain? The abdominal pain question on ABSITE is usually going to hint you at what are you going to do for a workup? What's going to be your signs and symptoms of something that is surgical? And usually you're going to look at, in a vignette, you're going to look for fever, you're going to look for tachycardia, you're going to look for other episodes, other things that show you on the vignette that the kid's sick, okay? Not every abdominal pain is appendicitis, even though that's what the ER tells you, okay? So labs in abdominal pain should be selective and focused and limited. Usually CBC and EUAs indicate if you have bilious vomiting, you can get some amylates, some electrolytes, really get a good history and physical. And when I say that, for this purpose, this lecture, really read the question. It's real easy to read a vignette, and in your mind, you get tunnel vision. You're like, 7-year-old very lower quadrant, oh, it's appendicitis. But 7-year-old with abdominal pain has been lasting for months. Okay, that's not appendicitis. It could be probably trying to talk to you about Crohn's disease or talking about Meckel's diverticulum or something like that. So really read the vignettes and type it down, okay? Radiology should confirm, not make your diagnosis. Routine, if they're giving you plain films, it's probably going to tell us something obvious on the plain film on an ABSITE question. Ultrasound is really the first line of choice now for just about anything in the abdomen in a kid. CT scans are still the most sensitive, but they're not going to want you to do those right away. Okay. We got to worry about where we getting, why we getting, what films. Ultrasound's better for, obviously it's good for pyloric stenosis, it's good for gallbladder disease, it's good for dilation, it's good in the right hands for appendicitis. But it's not good in a larger body habitus or older kids for appendicitis. And you also got to worry about bedside versus radiology performed studies. Lifetime risk of appendicitis is 8 to 9, about 9% in boys and about 6 7% in girls. Peak incidence between the ages of 10 and 18. We see it in every age. If the younger they are, the more likely they're going to present rupture. The appendiceal wall is thinner. The kids don't present to the pediatrician as quickly. Moms, appropriately don't bring their kid to the doc every time they complain of belly pain, especially the younger they are, because they can't tell you they're, and they'll perforate. As we talk about, ultrasound is great when you can do it. It may show inflammatory mass and is really best in thin children. CT, IV contrast is what you're going to do. Just so you know, for literature, oral and IV is the most sensitive, but rarely do you get oral contrast anymore, and IV is just pretty good. You got to look for stranding. When you're looking for stranding, that's from IV contrast. It's delayed venous drainage of the dye. That's what giving you stranding. You're looking for free fluid. You're looking for signs of valve obstruction. MRI can be done, but it's very accurate, but it's takes a long time, and a lot of times the kids can't stay still. We do laparoscopic appendectomies. You can do it with either 1, 2, or 3 incisions. A lot of them are being done with a single incision. Some of my partners do every one with a single incision, including perforated ones. We'll start with the umbilical incision and go from there. You can still do an open appendectomy. They're kind of rare. But actually, most one-port appendectomies are essentially open appendectomies through the belly button. You put a camera in and the sun grasp or pull out the appendix through the belly button, and then do an open appy. What will probably be on in some way, shape, or form is non-operative treatment of acute appendicitis. Just think about this. It has to be a kid who's not sick. If you want to do truly non-operative treatment. Later, less than 40 hours abdominal pain, white count less than 18, appendix less than 1.2 centimeters. If you have free fluid, appendicolith, or an inflammatory phlegma on any of your imaging studies, non-operative treatment for acute appendicitis will fail. The treatment is IV antibiotics for 48 hours and 7 days PO. Success rate is about 9 out of 10 in the chosen right kid to discharge, but a third of them will lose their appendix in a year. Now, there's not a slide on this, but don't confuse this with perforated appendicitis with abscess that then you perk drain. There's a kid who's really not that sick. You perk drain them and you do an interval appy. That's different than this. If you have a child that they're presenting for trying to set up in the vignette for a perk drain, antibiotics, interval appy, they're going to present to you a kid who's got right lower quadrant pain, mild fever, not tachycardic, non-tender everywhere except the right lower quadrant, and ultrasound, oh, by the way, shows a 10-centimeter abscess. Okay, that's the kid, and more than 7 days of symptoms, and so basically not that sick, even though they've had a long amount of symptoms. Those are the kids that benefit from a drain and interval appy. The kids that don't are the ones that come in with diffuse peritonitis, sick as snot. There's really not anything to drain. They don't have a single entity that's been walled off the drain. They got intra-abdominal sepsis. So anytime a kid with abdominal pain, you fix their dehydration, because either they're dehydrated as a cause of their pain or dehydrated as the result of their pain. So unless they have a contraindication, then you want to give them some hydration, give them a couple of fluid boluses, and a lot of times they just feel better. And if they don't feel better, they're actually better for an operation or other things. Other cause of abdominal pain, when the distal ileum gives you the middle finger, like Alex does every time he operated with me, that's a Meckel's diverticulum. Meckel's, again, lots of questions can be asked about Meckel's. Rule of twos. Two common presentations are pain like appendicitis or a painless lower GI bleed that actually causes the need usually for transfusion. It's not a little bit of blood, it's a lot of blood. There's 2 types of mucosa that are lining this thing, pancreas and gastric. So gastric mucosa gives acid, which then gives you an ulcer, which then causes the lower GI bleed. They're usually within 2% of the ileocecal valve. 2% of the population, 2 times more common in males. The two possible operations are you either do just a resection of the meckles or you do a bowel resection. The bleeding is caused by an ulcer that is in distal intestine and has got some inflammation that you need to remove the ulcer. So you got to remove the distal bowel. So Meckel's is the remnant of the omphallomesenteric duct of the intestine as far as when you're being developed prenatally. A urachus is the remnant of the urinary system that can persist at the belly button. So you can have a patent urachus. It can actually go from the belly button all the way to the bladder. You can have a urachal cyst. You can have a urachal, not a duct, but like a fibrous band. A lot of times when we do umbilical hernias, we'll find an umbilical remnant as being the cause of the persistent umbilical hernia. And we have resect it when we take on the umbilical hernia stalk. These may result, urachus can be resulting in recurrent UTIs or infection of the umbilicus. Abdominal wall defects are next. You either have omphalocele, gastroschisis, or bladder exstrophy. Abdominal wall is all about folds, okay? Lateral fold failures are omphalocele, caudal failure fills bladder, so distal folds cause the whole distal abdominal wall to fail. You get bladder exstrophy. Gastroschisis refers to interuterine rupture of probably an umbilical cord hernia. Gastroschisis defect of the anterior abdominal wall. All the intestines freely protrude. There is no sac. The defect is usually less than 4 centimeters and located to the junction of the umbilicus and normal skin. It's always on the right. Sometimes there's a skin bridge, but usually it's just an opening to the right of the umbilical cord coming out of the umbilicus. As I said, no sac. The most common thing that's associated with atresia is due to ischemia. The bowels thick and edematous due to an amniotic fluid exposure, which is acidic. Treatment consists of primary closure when possible, central access of TPN because there's a long ileus in this. Edema, maybe it's usually impossible sometimes to perform a primary closure. I mean, you can't put all this stuff in. This you can even think there's too much out. The domain's too small. You obviously have large bowel, small bowel. You can even have in girls, you can have their ovaries and fallopian tubes are out. There's an atresia associated with it. That's a bad problem. What you can do is if you can't get everything in, you put them in a silo. You serially decrease the silo by tying it down and getting stuff in. Then once it's in, you used to operate on these things. Now you just put a dressing on them and they actually just close. Kind of unfortunate for me. It's an operation I used to like. So you can immediately repair or you put a silo in. We rarely immediately repair now because it's just when you immediately repair, you're squishing everything in and they're in respiratory distress and the neonatologist keep calling you because they think they can't breathe. And so it's just easier just to put it in slowly. Sutureless closure is becoming the standard now. They still have delayed return of intestinal function. They can have atresia due to bathing in the amniotic fluid, which is acidic, or because the intestine is out, their blood supply can get attenuated and can get compromised due to just being farther away from the aorta, so it can get an atresia. Very less association with other anomalies other than those things associated with the intestinal atresias. Omphalocele is another congenital defect of the abdominal wall. It's lower incidence than gastroschisis. Bowel and viscera cover a peritoneum. The umbilical cord inserts into the sac. It is likely associated with multiple syndromes. The most common things caused with this are cardiac anomalies and pulmonary hypoplasia. And this is what it can look like. It can be giant. That's a medium-sized one. You see the umbilical cord coming right out of this thing. That's liver. This kid's not going to do well. So the omphalocele self-treatment is really dependent on the size of the defect and what's out. You can primary closure it. You can silo closure it. You can do these twist closures. We now use vac dressings for big ones to try and shrink them down. Otherwise, we just treat the sac and trying to get toughened up and epithelialized over time and then go back and let the kid grow and do serial reductions and then finally close. Think of midline defects. So again, the midline defects are there. Prune belly syndrome is sometimes it's just lax abdominal wall musculature in the lower abdomen, dilated urinary tract or bladder, and bilateral undescended testicles. Major GU issue is ureteral dilatation and blockage. Okay. Reflux is bad, and abdominal wall construction is usually done through an abdominoplasty. You tighten up and give them, you do like a big ventral hernia repair. Cloacal exstrophy is where the entire hindgut happens to be outside the body. This is the two halves of the bladder, and that's the colon come out of it, and that's an omphalocele hole. So that is, and then also what you don't see is that the pelvis is open. So these kids need to have orthopedics involved, need to have urology involved, general surgery. You bring out stomas, they close the bladder, and you stage the abdominal wall closure. Abdominal hernias will do quickly. You can have epigastric hernias, which are above the umbilicus and not a full thickness hernia. Not diastasis recti is not a hernia. You have umbilical hernias, inguinal hernias, and hydrocele. Umbilical hernias, everybody's got one. African American kids have a higher rate of umbilical hernias and a lower rate of spontaneous closure. They usually close by age 2 to 4, less likely in African American kids. Rare incarceration. We fix them if they're big like this at 2, or if they're small, we wait till age 4. Epigastric hernia is these little itty bitty, looks like peas, like abdominal wall defect here in the midline or a little bit off the midline above the umbilicus. It's not the diastasis where this whole thing is like wide. That's just linea alba has not been completely tightened up yet, completely formed. These don't resolve, but they're not a full thickness hernia. There's some preperitoneal fat that's poking through the interior fascia that sometimes is symptomatic, but they're not going to go away. Most parents want them fixed. I usually wait till this diastasis goes away before I fix them. Hydroceles, it's a patent process. This is the processus vaginalis, the canal between the internal ring and the scrotum. The blood supply and sperm cord goes through that. If the peritoneal lining is closed around it, you have normal anatomy. If it's open enough to let just water through, that's a hydrocele. If it has hydrocele fluid, but it closed after birth, that's a hydrocele. If the hole's big enough to let the fluid go in and out, that's a communicating hydrocele, otherwise known as a small hernia, because the hole's not big enough to let intestine in. If the hole's big enough, it's intestine. It's an indirect inguinal hernia because it's indirect through the canal. Indirect is laterally epigastric vessels associated with birth and associated with carceration more commonly in kids. Direct hernias are developed later. They're not congenital. So 50% of hernias are diagnosed the first year of life, but obviously considering how many hernias we do in adults that have an indirect component, that a lot of them are not diagnosed. The increased risk in twins, preemies, and hydrocephalus. Boys are more likely to have them because the testicles migrating down, and girls are more likely to have, if they have a hernia, the ovary is the most likely thing to be caught in it. Increased risk of incarceration less than a year of age. It's because the intestine's small enough to get through the hole. If it happens, you want to reduce it. I'll talk about that in a slide there. So here's the pain process vaginalis. You're going to close it. Here's the, you would do high ligation. Sometimes these is an old open repair. I went in back in later and did an happy on the kid. Looked in the sutured all the way up here, so I ligated it really high, which is good. Now we actually just close these holes laparoscopically with stitches around the ring, taking care to avoid injury to the vas and vessels. If you ever have to reduce a hernia, obviously not going to do it for a ABSITE. The trick is you want to put one hand over the external ring, the other hand on whatever the contents are, and you want to pull and kind of try and straighten them because they're kind of twisted. Pull and then try and reduce some of the fluid, and then try and move it back in as mass, in one mass. Undescended testicle, rarely on exams, but you want to If it doesn't descend by a year, it's unlikely. If you have an undescended testicle at a year, you're going to operate. They can be anywhere along the canal. You can stage them if you need to. By staging them, what you can do is Stevens-Fowler is an old system where you actually ligate the gonadal vessels, but leave the gonad in situ. There's small blood supply on the vas, and the idea that if you ligate the gonadal vessels and leave the vas supply intact without doing any other dissection, over 6 to 8 weeks, that blood supply will hypertrophy, and then you can bring it down on that stalk. Now we can actually do a lot of laparoscopic dissection, dissect out the gonadals retroperitoneally all the way up to the kidney to try and get much more length to get it down. Acquired undescended testicle is something that is being seen. Is a question of good documentation that the testicles were descended and then they rise up and don't come back down again. But again, that is probably not something coming in the ABSITE. Circumcision, why do you do it? It prevents paraphimosis. It does lower UTIs. It is medically unnecessary, but there are some small indications to it clinically. It does decrease your risk of STDs and HIV if you're a circumcised male. Skin and soft tissue infections, things that sometimes are on the ABSITE is MRSA. Community-acquired MRSA has a toxin that's expressed in it called the PVL toxin that causes soft tissue necrosis. That's the main thing, in that we don't flame open, we put drains in. Hidradenitis, if you have axillary or groin that are chronic draining sebaceous gland infections, hidradenitis now is getting treated by I can't remember which one, but it's one of the biologics. Everything is immune, TNF inhibitor will treat that chronic bad hidradenitis. Pylonal cyst disease, the bane of our existence, also I'll have a slide on that. But you can drain them, you can put drains in, you can pack them. Antibiotics for ABSITE, if you're adequately drained, soft tissue infection does not require repeat antibiotic therapy unless you have signs of systemic disease or cellulitis. Okay, that's actually may come up. Pylonal cyst disease, pylonal tracts become cysts, become infected cysts. Surgery is incision drainage of abscess only. You can do a hole punch and just excise the sinus tract. That's called a Gibbs procedure. There's a couple papers out there now that says just better hygiene helps recurrence. Big surprise, soap and water. Trauma in kids next. The most common cause of death and disability in children is still trauma. Goal is to stabilize first. What causes kids to die after the incident? So if they make it through the incident, what causes them to die? First thing is airway and breathing. Last one is failure to recognize hemorrhage, either in the abdomen or the head. So if they make it to your ER, those are the 4 things that are going to cause them to die. PEDS is still the most common cause of death and disability. Death by firearm is now surpassed death by motor vehicle crash in kids. Death by firearm is the single highest risk of death in kids in the United States now, higher than car wrecks. That's sad. And the other thing that comes up is sometimes the minority of treatment of patients who undergo pediatric trauma are actually treated at trauma centers that are kid trauma centers. Age relationships. So if you think about infants, you got to think about non-accidental trauma or improper call sheet or true accidental drops. Toddlers can ingest stuff. They fall. They burn themselves. They're passengers. In preschool, we talk about, the kid airbag. When I was in Kentucky, where the parents would hold the kid in the lap and the airbag would hit the kid. Elementary school, you get into bikes and sports. And then when you get into high school, you get into, hey, pal, watch this self-stupidity stuff that you get. And now we're getting more and more firearms. We're getting at least one to 2 firearm injuries a month now. ATLS is still the answer. Airway, breathing, circulation. Breslow tape is when you come up on website. What's a Breslow tape? It's a tape that estimates the weight of the patient based on their length, and it gives 2 types of data. It gives you the weight-based drug dosages on the sheet, and also gives you the tubes that you need, the size of your NG, your Foley, your chest tube, your endotracheal tube. So it really is helpful, and the guy made no money on it. Airway, thing to remember for ABSITE is short interior airway. You can't crike a baby up to about age 9. If you try and crike somebody, you'll put the crike into their esophagus. It's too thin and too narrow. So if you do have to do a surgical airway in a small child, it is a trach. And now we can say in the last year we did one. We did a emergency trach on a 4-year-old who got shot in the face, who was coding, and we were able to get it in. So we had no crike, and less than 11 or 12 years of age, you don't crike. Chest wall is compliant. You get lung injury without rib injury, so look for pulmonary contusions even without rib fractures. Thing to remember about kids is that they kind of fall off a cliff, okay? Their blood pressure stays stable even though they're getting more and more tachycardic. Then what happens is they get stage 3 shock, they plummet, and then they die, okay? So tachycardia is more sensitive, that, tachycardia, that once you've treated fear, once you've treated pain, that make you worry, because their blood pressure is going to persistently be good until it's too late. You want a good IV. Venous access, anything peripheral, IOs, femoral, external jugular vein. You want to get some blood for labs if you can, but don't lose your IV. Boluses in children now, for just the last couple years, used to be 20 per kilo times 2. Now it's 20 per kilo times 1. Then blood, just like now in adults, it's 1 liter, then blood, as opposed to 2 liters of blood. You want to watch for decreased heart rate, increase in sodium, improved pulses, warmer extremities, and you start looking for urine output, okay? Blood loss can, the 5 places blood can be lost in the trauma: the chest, the abdomen, the retroperitoneum, more than 1 long burn fracture, or the street. In infants, you can also bleed out. So you can bleed out in these areas. In infants, you can also bleed out in the head, as long as you have a fontanelle. So babies can have stage, grade 3 or 4 hemorrhagic shock with just a head injury. Glasgow Coma Scale, the same thing. Basically, vocals different. It's appropriate interaction for age, cries but consolable, but everything else is about the same. You want to get an ample history, including immunizations and with their meds, and that's one thing to remember. All right, head CT, neck evaluation. You want to know that there is something called Skiwara, spinal cord injury without radiographic abnormality. It is real, but it's usually associated with a TBI. So if you have a kid who you can't examine their neck, leave their collar on, okay? So they're even if you don't have plain films or even CT scan that's normal, leave their collar on, because ligaments injuries are real. That's gonna give you Skiwara, and you're gonna miss it in the kid with the head injury. Chest trauma, again, we talked about. Abdominal trauma. Kevin, kids are soft compliant abdominal wall, just have a soft compliant chest wall. So force is dissipated through their abdominal organs. It's usually absorbed by the solid organs first. So spleen and liver are roughly equal, and they're the most common things injured. Fast is pretty good in kids, but remember, fast is not something you do once. Fast is good if it's positive at the first time, it's great, but if it's negative, you may have to redo it. Okay. If you're getting contrast on the belly, you're going to do when you want IV contrast. All right, splenic and stuff like that. Another question that comes up is lap belt injury can be associated with a hollow viscous injury. Worry about CAT scans that show free fluid without solid organ injury. If you operate on them within 24 hours, their outcome is the same. So if you have some free fluid and the kid's got some pain, but he's not tachycardic, you can watch them. But if they get tachycardic, if they spike a fever, if they start having bilious vomiting, you got to explore them. Okay. Non-accidental trauma is the most common thing, unfortunately, we see anymore. Any kid less than 1 year of age with trauma needs a non-accidental trauma workup. There we go, child abuse. Last thing on this thing is tumors. We're actually making decent time. Neuroblastoma. What do you got to know for the test for neuroblastoma? Okay. 50% are diagnosed by age 2. So neuroblastoma is the most common most common solid tumor in children. And the reason why is it can occur both above and below the diaphragm. It can be in the chest, along the sympathetic chain, or it can be in the abdomen, the adrenal, the organ of canal, anywhere along the sympathetic chain. Survival is age dependent of diagnosis. If you diagnose these things before age 1, it's great. Before age 2, it's still good. After age 2, it's horrible. Okay. And it's just because it's just had time to grow and metastasize. It's the third most common pediatric malignancy, and the first 2 are leukemia and lymphoma. So most patients have advanced disease at the time of presentation. And if they have neuroblastoma, they're going to either present by age 4 or they're going to die. Then, because they're usually, if it's true neuroblastoma, they're going to die before age 4. It arises from neural crest cells. Endemic amplification is one thing that comes up, is assumed with a poor prognosis. The younger a patient is, the more favorable outcome by prognosis by stage. So the younger you are, theoretically, if you're 6 months of age and have stage 3 disease, you'll do better than a 4-year-old with stage 2 disease. Okay. Staging is confined to the organ of origin, spread not across the midline. So if you're in the adrenal gland, you spread to the kidney. If you're in the adrenal gland, you spread across the midline. Distal Mets. 4S is a special subset of neuroblastoma in infants, where it's skin and bone marrow, less than a year of age. A lot of times these kids, it's really weird. This will sometimes burn out on its own without chemo, and they'll just survive. Wilms is the most common malignant tumor of the abdomen in children. The 500 new cases a year. This is one where surgery still plays a major role. Cure rate is great. If you can resect this thing and not rupture it, that's a lot of times all they need, no matter what size, as long as it's the right subtype and the right biology. They sometimes don't even need chemo, no matter what the size. But if you rupture it, they will. Associated with germline mutations. Beckman-Wiedemann syndrome will come up sometimes. That's Becker-Wiedemann syndrome and Wager syndrome. The things they like to ask, it's the esoteric zebras. But Beckman-Wiedemann syndrome is something that I've actually seen clinically. And these kids will get Wilms at some point. Okay, watch ultrasounds. Preoperative chemotherapy is supported if you have bilateral primaries, or a case of primary kidneys, if you want to try and do a partial nephrectomy, or IVC invasion extended above the hepatic veins so that you can shrink that tumor clot and get it out of the IVC for resection. If you're in Europe, this is one thing that differences in Europe versus America. In Europe, any Wilms tumor gets preoperative chemo before resection. In America, if it's deemed resectable by imaging, we go resect it first and try and avoid chemo if we can. This is bilateral disease. That's Wilms. Rhabdomyosarcoma, soft tissue tumor. This is the one that can be anywhere. This one you biopsy, chemo, and then resect. This is the one where there's lots of types and lots of locations. Okay. So embryonal spindle and Boytrude are good. This will be on, I will put the whole thing up, but rarely are we asking this anymore. But rhabdomyosarcoma is one of the ones that is more dependent on location and subtype for prognosis. Sacrococcygeal teratoma, big mass coming out the butt in a baby, is usually not malignant. Usually it's a really big, benign teratoma. Rectum and general surgery usually displaced and not involved. It's got 4 types. Most common type is a type 1, where it's completely extracorporeal. Then there's a type 2, or think about dumbbells, so two halves in and out. Type 3 is same thing as 2, except more is in than out, and type 4 is all in. So all out to all in. Dumbbell E2 is equal inside and out, and more, type 3 is more. So just as you follow it across, completely in, completely out to completely in. All three germ layers, that's what makes the teratoma. Most are benign, but they can be malignant. You follow these things with alpha-fetoprotein, and you follow them for life and make sure they don't recur. Teratomas can be anywhere. So sacrococcaleal teratoma have a high alpha-fetoprotein. Teratoma is the most common place for a teratoma is a female ovary. If we're pretty confident they're teratomas, as in they're calcified, there's hair in them, something like that, then we'll try and save a portion of the ovary and just enucleate the teratoma, no matter what size it is, from the normal ovary and try and save the rest of the ovary. But there can be other carcinomas, and workup is a bunch of lab tests for ovarian masses. Liver tumors. Hepatoblastoma is the most common liver tumor diagnosed in children less than 4 years of age. Alpha-fetoprotein is again elevated. So this is usually an asymptomatic mass that we see in a toddler. It's a liver mass, and then their alpha-fetoprotein's up. If you're in America, you want to resect it. If you're in Europe, you want to chemo it. So what we have now is something called pretext imaging. Pretext imaging is also in stages. Depends on how much liver is involved. So it's backwards. If you have stage 1, there's 4 sectors of the liver, 3 are clear. Stage 2 are clear. So it can be one big mass invading 2 sectors, or 2 independent masses, 2 sectors. Stage 3, only 1 sector is clear. So you're gonna have to do a trisegmentectomy on this one. This one, anyone stage 3 or higher, you're going to pre-op chemo and try and shrink to make an unresectable tumor resectable. Okay. If so, stage 1, basically, these are all cured by resection. You can just take out 1 section and they have 100% survival. Stage 2, if you can tease these out, obviously this middle one's going to do better than this one. This one, I would, if it's involving the hepatic, the bifurcation, I'd probably shrink with chemo first and go from there. Stage 3, they're going to need pre-op chemo. Stage 4, they're going to need pre-op chemo. If it's unresectable, you can do a liver transplant for hepatoblastoma. 8 minutes to spare. Questions? All right, what I'm going to do is I'm going to share this presentation in the chat, and you can copy and paste it. And then this also was recorded, and I'll try and download the recording and put it up either here or YouTube before I leave. Okay? So let's see. All right. The talk's coming up. It'll be in the chat in a second. And if otherwise, I will try